So if you'd like to just start by saying who you are.
So my name's Sohier Elneil. I'm a urogynecologist based at University College Hospital in London. I'm also work in the Department of Uroneurology at the National Hospital for Neurology and Neurosurgery. So I do look after women who've got basically complex pelvic floor disorders, not just neurological but also non-neurological problems. And as far back as 2005, I became aware of the problems women were suffering with as a consequence of not just mesh, but the access to care for problems they had following mesh insertion. And the reason I brought in the two sort of sectors is because a lot of the women were actually referred to me in the neurological hospital for pain management initially, rather than in the main sort of women's health division. So that's the sort of background that I come from. And over the last decade and a bit, we've been sort of working increasingly with women who've had difficulties as a consequence of implants, various implants.
And before I ask a question on conflicts of interest, which I'd like to explore with you, can I just ask you how long you've been associated with mesh?
So I've worked with issues with mesh really from the time of my training. So as a junior doctor both at Cambridge and at University College London, it was part of our training to also be involved in learning how to put in mesh, and it was part of our, basically to be signed off as a urogynecologist, you had to learn how to do the procedures. It was part of the requisite for your training. When I became a consultant in 2004, the advice at the time was that mesh was a good option for women with stress incontinence. So many of us were advised to use it as a therapeutic option after patients had been through the usual pathway of care for stress urinary incontinence and prolapse. And subsequent to that, I still maintained my skills in other different types of surgery, so that it was possible to offer women the whole sort of armamentarium of surgery rather than a specific single track. So
you don't do obstetrics?
I don't do any obstetrics, no.
No.
Not since I've become a consultant.
Right, okay, thank you very much. It has been raised, brought to our attention by other bodies, that there is a bit of an issue with conflicts of interest. Conflicts of interest associated perhaps with the regulator, but also with surgeons. And I just wondered if you'd like to tell us a bit about that, if you feel it exists, if you think that there are things we should address.
Yes, I mean, I think certainly in the early parts of the 2000s and up to probably 2010, it wasn't unusual for many doctors to be supported by different pharmaceutical companies and implant device companies to go to meetings, to support their research, to help them with meetings in their hospitals and to support them with basically progression in their clinical arena of work. I mean, I'm just perhaps one of the few who did not have any such intervention or any such relationship with the particular mesh companies. I will agree that I've worked closely with companies, the implant device companies like Medtronic, which have used sacral neuromodulation, and pacemaker device companies, and in the past with Allergan, who does Botox in our patient group. Those are the sort of predominant groups I've had work with, but not with the mesh companies. And I think what I have learned in the last few years, it's been a learning exercise for many of us, is that many of my colleagues were involved quite closely with various mesh companies.
You said since 2010. What's happened since after 2010? So
in 2010 there was a sort of a very strong directive that doctors and physicians in the UK, and it came really from the pharmaceutical industry directly.
It came from
the pharmaceutical industry, that they had to make it extremely clear for what purpose money was given, and it should not impact on your judgment call to use specific medicines or to use specific devices or implants. So there was a very sort of strong drive, and many people sort of tried really hard to adhere to that. There were also, if you sort of looked at the converse, one of the problems was that a lot of people to actually attend meetings and international forums and so on, it's a costly affair, and for many people it impacted hugely in their ability to go to those meetings. But it was expected that you had to be upfront, be very transparent about what you were using, why you were using it, and so on. So that was a very sort of strong directive, and most hospitals made sure that clinicians working in the field were well aware of the rules.
So, talking about the meetings, which I can understand could be very useful for training purposes, if it's made very transparent who is putting on the meeting, who is funding it, and when the surgeons or whoever goes to those meetings, it's made plain. Do you think that deals with the conflicts of interest?
I think as long as you're upfront about it, it should have dealt with most of the conflict of interest. What's come to light more recently is other funding opportunities which were not so clear. But for instance, all the societies request that you're upfront. You have to do a disclosure agreement. It has to be on the website under your name. Everybody needs to know in what capacity you acted with that particular company. But there have been other things that I've become aware of recently where there was funds given for other reasons which were not perhaps so obvious to the rest of us. But that's also that was taken on a personal level, so it wasn't something you could judge people on. That's how it happened in that facility or that institution.
So I don't understand.
So for instance, some people had research projects, for instance, funded by certain groups or certain companies. So you wouldn't necessarily be aware that that's been happening in the past. It's only now that people are aware that that's what's happened in the past.
So is there clarity now, or is there still a bit of an undercurrent?
I think there's more clarity now, definitely. My impression is most people are talking about what's happening.
But I mean, if you have a research project that is funded, if you publish anything from that, you have to declare.
You do. You have to declare. It has to be on the publication, and the journals will ask you for that.
Yes.
Otherwise, they will not publish it.
Yeah.
Right. Thank you very much. Can I just ask you? I mean, clearly, a lot of the work that you've been doing has been taking out mesh, doing the removals, either partial or whole. But are there issues where you think there are reasons where you really should insert mesh? And also, if you feel there are occasions when we should have mesh alternatives, and if so, what are those? But the first part is, are there times where mesh should be used?
That's a very difficult question. I think there will always be patients who need mesh, but it really is the last resort. And other therapeutic options should have been offered and trialled first. And if there's then a failure and there is nothing else that is possibly available, then yes, there is a role for mesh. I think what happened to us in the field has been that mesh was always kind of a second or third, had a second role or a third role in the patient's pathway of care, but it kind of moved up hugely and became almost the primary therapeutic option offered, and I think that might have contributed a little bit to what's happened to us in this field. I think it has got a role, but it has to be very, very clearly well defined, and in addition, I think the high vigilance state that we've got now should apply to that, so these patients must be followed up regularly for the rest of their life, and not to be discharged and not seen in the community.
And we're talking specifically about pelvic mesh insertion into the pelvis. Yes. Okay.
Yes.
Because there are other areas, perhaps.
Yes.
Hernias and things like that. Okay. Right. Yes. Any questions?
Can I just ask, who should be putting mesh in? I mean, we've got now, when we've seen the sort of specialised commissioning framework for dealing with complications, but it sort of rather leaves the putting in of the mesh much more local.
Yes.
Where do you stand on that?
So, I mean, one way of looking at it is you could say there should be the good mesh guide or the good mesh insertion guide, and that would be in centres where patients have access to the therapy, but really within a setting where it's not just generally used or passed through a rubber stamping sort of system. I think one of the problems that has occurred has been, for instance, the concept of multidisciplinary team meetings to make decisions. But in many situations, it's quite clear there's almost a rubber stamping approach to that. So depending on who's the most vocal in the group, and we are starting to see this, and this is why some of the work we're doing now with mesh removal needs us not to work like that. We need to be much more aware that just okaying something because the majority of the group think it is, without sort of having the voice of dissent there, is not appropriate. And I think with mesh insertion there is a drive to sort of just say, well, it's appropriate, it's good, just use it, and anybody can use it. The training has not always been up to speed. Many people who were inserting mesh, certainly from my experience in removing it, often were not urogynecologists or female urologists. They were in name but not necessarily in training. There wasn't a distinct sign-off process. There wasn't a mentorship program in place or supportive program in place for ongoing membership and preceptorship and support. So I think if where we are now and where we'd like to be in the future, I think that would have to change. We'd have to have a much more sort of almost like a hub and spoke approach, where you'd have patients through a very sort of a centralized group of assessment, but with if you're going to work with peripheral units to work together, so that you can say, well, this is we think this patient should have X. We know this centre can provide X. They can be seen in that centre. There needs to be a bit more freedom of movement, but with a directed sort of core of assessment and vigilance for that patient.
So can I just be clear, are you saying that the MDT approach per se is not the answer?
Not always. I think it is in a lot of situations, but it's not perfect. It's not perfect, and it is very much dependent on who the members of the MDT are. It depends on the voice of the members, because some people's voices are, let's say, more equal than others, and therefore that has an impact on how the decision making goes. And that's something that, as physicians and clinicians, we've got to address. How we address it, I'm not sure, but it's something we need to think about.
In the hub and spoke approach that you're suggesting, if you're suggesting sort of centralised hubs, how do you determine where they should be, who they should be, how do you accredit them, how would that work?
So most major units act as a focal point anyway for complex pelvic surgery. So you could actually use them as your hubs already. They've already got the focal group of surgeons working in them. They've already got usually the training throughput and the trainee throughput and so on. But actually creating a way that they could communicate with, either they could be the people who refer into them or the people around them, or geographically that works with them, so that everybody feels equal in the decision-making process. I think that's quite important. Because I think there is a tendency, and before coming to this hearing I did inquire from my colleagues in district general hospitals around me to see what their thoughts would be, and many have said that they feel kind of outside the process of decision making. Even the current situation with the mesh, they feel they didn't have a word or a say immediately, but they quite welcome, and it was their suggestions actually. They would feel much more secure if they had a central point they could work with, refer to, take decisions with, for their own patients as well as for the centre's patients group, the group in that particular centre. It's a bit more complex, I think, than what we've got currently, but it may be a way forward. Yes.
So would it be mandatory that, say, you're a surgeon in the spoke in the district general hospital, that they would need to get clearance from the hub, UCLH, if it was there, Northeast, to actually put mesh in any way into a patient. Is that what you're saying?
I think that's, I mean, when I spoke to two of my colleagues, in fact 2 of them last night, they made that point that it actually would validate the process if they knew that what they were doing fits in with the guidance, because most of the hubs are working very hard with the situation we have currently to try and make it strong. The spokes, as it were, haven't got the same, they haven't got the support fully. They can get it, but it's going to be difficult if you're in a spoke. So actually buying into the hub and having that input actually makes their life much easier.
So a woman goes to see somebody in Essex, and she's got stress urinary incontinence, and they decide together that this is what they want to do. They would then contact you, send you the history and what they intend to do. And all this, of course, will be open because the copies of letters to patient. And then that would be cleared off. Yes, this is the appropriate thing to do it. And then, of course, it would be registered on the new register.
Yeah, in the new non-partisan register, as I refer to it. And I think that, so it needs to, I mean, we've adopted a method for the last 2 years which has worked to some degree, although I don't think it's as fine as it should be. But it involves using technology to Skype in and talk to each other once a week so that we can discuss complex cases together. And we've found that even, although I'm based at UCLH, so it's in theory a hub, I'm not suggesting it should be the hub, I'm just saying it is a possible hub, is that we found it as helpful to us getting that perspective from the community as vice versa. So our community colleagues in the DGHs will, say, well, hang on, this patient lives in such a place, we think this may be more appropriate. So we've had that dialogue, and I think it's been helpful to us. It's not perfect, but it's certainly a different way of doing things.
But that would be particularly for mesh. The other interventions for stress urinary incontinence wouldn't require that process. No, they wouldn't. I think because of the situation we have with mesh, it might be a very good way. We've done it for everything. We've done it for all prolapse and continence surgery, and that's been helpful to us, chronic pain, etc. So we've done it that way.
So if a surgeon and the patient agreed that it should be carpose suspension.
Yes.
That would be part of this scene altogether?
At the moment, we do that, Our unit does that. Even if you want to do a corpus suspension, we pass it through all of us. Is that okay? Are we happy? Yes, we are. Fine, we'll go ahead with it. But I suspect in the future, because at the moment we haven't got the clinical skills for everyone to do a corpus suspension, we are in a difficult situation. But if all things were equal, in theory, because it's a non-mesh procedure and it's not an implant, then yes, in theory you could do it locally in your local group assessment. But for the time being, I think for the next, certainly the group I'm working with and who are working with me, we feel we should discuss them all
So
together.
that wouldn't be part of the registry?
No, I think, to be honest, Baroness Coverage, I think what's happened with stress urinary incontinence over the last, it's not just what's happened with mesh now, but the mesh that even dates back to the 80s. And the fact that the follow-up data has been poor in urinary incontinence generally, I think it may be sensible that all urinary incontinence procedures should be on a database. Mm-hmm. That would be, I wouldn't see any difference. I would expect we should do that, because it has a long-term consequence on the quality of life of women. We don't know the efficacy long-term because we have not kept good data. We don't know what other possible complications can arise. Corpus suspensions also had their own issues years ago. So it's not that it's the perfect alternative. So I think until we're up to speed, training-wise, everybody is equal, which will take years, maybe another generation. We should have everything done properly on a database.
In terms of surgical skill at the moment, is there a sort of feel about a lack of surgical skill with the traditional non-mesh techniques, and how widespread is that? And if you just said it, you think it would take a generation?
Yeah, I think it will, because there is a group who have, my perspective, there's a group who've been in positions as consultants for, say, the last decade. Many of them have lost those skills. They did have them at the very beginning, but they've lost them. They could probably relearn them. It will take time. But we've got a group in the middle, what I call the 5-year consultant group, who have never learned them. They need to completely relearn. They're going to be the ones seeing out the next decade and a half. So that's really another generational group.
Could I just ask about your experience in terms of mesh removals as one of the very few specialists in the country currently doing it? I suppose I'm interested in knowing if a woman presents and you've agreed to conduct a full removal, how often is it that you're unable to conduct the full removal and it becomes a sort of default partial removal?
Yeah. I think I would say, so we tried in the beginning to scan everybody before and after, and now we're doing it a little bit more often. Difficult to say. I would say most patients with obturator meshes, which are the transobturator, I am sure most of those patients have got something left behind, a little piece. How much is dependent on the type of mesh, the approach, etc. With regards to the retropubic mesh, they almost are always total removals because the angulation is under the urethra, so we usually do it in 2 steps for many reasons, but one of them is that I think from a morbidity perspective it's better for patients, that's my personal view, but you remove the vaginal portion and let that recover, and then you bring them back 3-6 months later, by which time you also know if they've got recurrent stress incontinence. You then remove the abdominal or pelvic portion separately, but at the same time do either a colpus suspension or an autologous fascial sling to treat the incontinence. So we do it in 2 steps. Now in those procedures, particularly if you do the dissection over the bone and into the vulval tissue, you will get it all.
Right.
The problem comes in technique and what people's perception is about what really needs to come out, rather than. So for instance, if somebody says I have pain at a particular point, some clinicians will think, well, just remove the mesh from that particular point, not necessarily all the others, but we tend to do complete removal. So retropubic meshes, I'd say total in 2 stages. Transobturator meshes, we think about 30% always have a little residual bit left behind, but we're currently sort of trying to develop our scanning technology in-house so that we can actually scan during surgery, so we can actually modify and see whether there's any residual mesh at that point.
Can I ask about when you remove the mesh, are there any, in your experience, are you seeing inherent defects from the mesh that you're removing, or are you witnessing poor insertion and the effects of that?
A lot of poor insertion. So mesh in the distal urethra, proximal urethra, not in the mid-urethra. Folded, too tight, etc. You can actually see it taut across the urethra. The mesh itself as a characteristic, you can't honestly say it's the mesh that's done the problem, other than sometimes you will see abscess formation, you will see inflammatory change, you'll see like nodular tissue around it. So almost a chronic, the best way I could describe it is a host versus graft reaction that you would see, say, in transplant surgery, where there's an attack of the body on the product. And that's the sort of change I could see. So it's induced that response. We've got some meshes that I have seen where they haven't crumbled, that would be the wrong word, but they've sort of almost snapped on themselves, and so you've got sort of slightly movement, but they're rare. You don't see that often. You tend to see much more either the very sort of inflammatory change or the malposition or misdirection of a particular part of the mesh.
But the majority of the problems you're seeing are caused by insertion issues rather than by inherent.
I think insertion is definitely a factor. We have got, of course, our proportion of patients where it's in the perfect position, it's in the mid-urethral point, etc., but still they've got problems. So in that particular group, We think it's the inflammatory response, which is not always visible to the eye, but it is when you remove it, send it off for histopathology, and it shows very chronic, bad inflammatory change.
Can I also ask about translabial scans? There seem many women have to almost fight to get access to a translabial scan, but amongst the clinical community there seems to be a split of opinion on how useful translabial scans are in determining whether mesh is present and where it is and so on. What's your view on translabial scans?
Up until 2016 we never used them, and then that was mainly because we didn't know how to image the mesh. We kept on trying to find ways. We tried MRIs, it didn't do that. I think as physicians we always want to know as much information as possible before you enter a difficult arena. So what I have found is that subsequent to when my colleagues started doing this, it has helped me understand more why the patient was having a problem. So it gives you clarity on the position of the mesh. It tells you whether the mesh is breaching the muscle, the mucosa, the urethra, the bladder, so you are prepared for the type of surgery that you might need to undertake. You also can prepare the patient better. So you can say to the patient, look, you're going to need to have a catheter for 14 days. You're going to need to have a cystogram, etc. So you're better prepared. I think there is a resistance by some to the understanding or to the role imaging has, but I think also for clarity, for me as a surgeon, the more information I have, the better I think the decision and the surgery potentially will be, because I know what I'm dealing with rather than not what I'm dealing with. So we've had occasions where patients had a perception they had a retropubic mesh when actually they had an obturator mesh. So that kind of changes your scope of approach. We've been told that patients would have come and told us we've had 2 or 3 meshes, but they actually might have 1, or vice versa. They thought they had 1 and they've got 3. So in situations where the mesh is physically easy to see, feel, you know it's there, it's eroded through, that's slightly different to the case where the pain is a factor, we don't know why. I find it very useful then.
Is there no alternative? So you couldn't have found that information any other way than by the translabial?
Yeah, it can be, so my colleague, I spoke to her who does a lot of scanning, she uses an endovaginal technique. You don't need to necessarily use translabial, but you just need to know what you're looking for and how you're looking. So she uses an endovaginal process. She usually uses a 2D probe. She doesn't use a 3D necessarily, but it just gives you clarity of where everything is. And because it's a difficult arena, and it is a fraught arena, I think you do need as much information as possible.
So the problem isn't the equipment that's generally available,
no.
It's the operator.
It's the operator, and the operator who knows what they're talking about. So I get more information from my colleague who's also a urogynecologist as well as a detailed scanner, because she's got that experience, than I do from somebody who doesn't necessarily have the urogynecology background. They can tell me the mesh is there, but it's not always as helpful to me as a urogynecologist. But that's something that can be worked on.
But you can pay X £100 and go and have one privately, can't you?
Yes.
And that's being done by somebody who's not working in a multidisciplinary team.
Exactly. And so the information because I see a lot of patients who've done that, the information I gather from that source has not been always helpful to me at all.
Ms. Elneil, I'm afraid we've got somebody else coming now.
Okay.
But can I thank you so much for coming? I'm very conscious we could go on a lot longer.
Oh, not at all.
But if we have further questions, perhaps we could put them to you. And if you have questions to us,
sure.
We would welcome them.
Sure.
But thank you so much.
You're very welcome.
Thank you.
Thank you.